Okay, I'll be talking about managing diversion risk. First, going to talk about why buprenorphin's prescribing is important, some red flags, managing diversion, and then we should have plenty of time for questions. I put some slides in here that I think are topics of debate, so hopefully that can happen. So this is just data that you guys are probably familiar with, and just about opioid overdose deaths that have been steadily increasing, revised in 2018. So this is best practices that are occurring in some states. And you should have this in front of you, so I'm not going to read it word for word, but basically buprenorphine should not be withheld from patients using other substances, including heroin, ongoing heroin use, cocaine, etc., because the harm caused by untreated opioid use disorder outweighs the risks. Not treating opioid use disorder, rather. And then, of course, there's we all know that benzodiazepines combined with buprenorphine has been warned against in the past, and then that for overdose death, but that was recently, I guess, kind of taken back by the FDA. So there's that too. And then, of course, buprenorphine maintenance can decrease morbidity and mortality and reduce overdose death. So red flags for a patient who may be diverting their medications. Early refills, it's necessary to figure out what's going on with the early refills. If they are increasing their use to, for example, treat mental health symptoms or possible withdrawal symptoms, if they say that they have lost or stolen films, it's important to inform your patients that most providers aren't responsible for lost or stolen films, and that a lockbox should be utilized. And then tampered urine, that can be using fake urine, spiking the urine, and that can be patients dipping their buprenorphine into their urine, or when it's dissolving in their mouth, they can spit into the urine. That can be evidence. There can be evidence in that on the GCMS, not necessarily the immunoassays. And then, to address risk for diversion. So first and foremost, I think it's important to manage patients' expectations and to set the standards for the treatment program that they are in. Before starting a medication, Suboxone, reviewing the standards of treatment and addressing, like, not responsible for early refills, lost or stolen supplies. Don't elevate your dose without talking to a provider first, and this may have to be reviewed throughout the course of the treatment. We use GCMS or LCMS to monitor adherence to our treatment regimens in our clinic. So we have Bup and Norbup in our urine tests and checking for other drugs of abuse. Generally avoiding doses over 25 milligrams. There can be cases where 24 milligrams may be needed. For example, if they're on a medication that increases the metabolism of the buprenorphine, then they may need a higher dose. Corroborating information with the patient's consent. And then if a patient has been not adhering to the treatment recommendations, then having weekly follow-ups, writing weekly or biweekly prescriptions, and having patients come in for film counts, wrapper counts to make sure they're not diverting. And then if a patient isn't successful in an outpatient treatment program that you're unable to see maybe more than once a week, then they may need a more structured environment, such as at a daily dosing clinic. Also, this is my next slide. So then if you are transitioning a patient to a daily dosing clinic, I usually have them make an appointment during their visit with me to get into that daily dosing clinic, and then also bridging them to get there if necessary. But here we can get them in fairly quickly within days. And then because the risk for overdose death is very high once they stop their treatment. Yeah, so that's all I have.
Great, thank you, Elise. One clarifying point, because the FDA guidance that came out within the last year around concomitant benzodiazepine use was interesting, and it's good to dig into a little bit.
Okay.
And the spirit of it, I think, was targeting more behavior that we've seen quite a bit, where if someone comes in and they're reporting benzodiazepine use in any form, that was frequently viewed as absolute contraindication to even considering opioid agonist MAT. And the guidance, the FDA, they still encourage moving to taper, ideally discontinuation. So that they aren't specifically like encouraging, oh, just keep the benzodiazepine going and the buprenorphine going. And I just wanted to make sure that everyone was sort of clear on that. Because again, particularly with methadone, I think a lot of places in the past had sort of said, oh, you're taking benzodiazepines, we just can't see you at all. And I think the FDA really wanted to discourage that.
And I think also, if it's based on a point of care urine drug screen and they don't send for confirm, and there are some false positives for that, sertraline, for instance, can sometimes trigger that one. So it's and it's hard for anything to be dogmatic, but I think the reason, I don't know, there were all these stories anyway of people being cut off of whatever their other opioid was, even before buprenorphine entered the market, and people would just react sort of knee-jerk without thinking it through. So yeah, I agree. I think it was addressing that, but it didn't say this is sort of freedom to write for both for as long as you want.
The other thing, just to hear about sort of how other folks practice it, is I've received myself sort of different messages around the counting of medications, particularly when they're controlled substances, where specifically I've heard from different folks that the health professionals shouldn't be the one pouring those out and doing the counting, but that the patient should be doing the counting in the presence of a health professional, but didn't know if other folks had heard that being sort of a rigid
Any particular
guidance.
question about why? Because I mean, I've wondered about when I've often had the person bring in their film wrappers, and we'll count them sort of together. Like they'll give them to me at the table, and we'll just count through them and be like, there should be 21 in there, and yep, there are 21 in there, and then we throw them away, and then we're kind of done. But and those are the wrappers, not the actual whatever's left over. But the other thing that I think about is with all of these, as good as you think this is, all somebody has to do is say, hey, when you're done using that, give me the wrapper because my doc wants to count them, right?
So it's certainly
and you
not
go to
cool
extra
for,
length.
Right.
Don't the cereal.
You don't
we actually don't do much for counts unless we call somebody in for a random, and they should have medication left. The rest of the time we don't bother.
Yeah, and I think that's a great point to bring up. Yeah, we don't do that universally either.
Yeah.
But if repeat concerns come up around an early refill request or a non-reassuring urine test result, then we may do that for a time. That's a very good point and an important one. Yeah, we aren't doing that universally.
And also, Elise was just saying, I've read about and tried this once of looking at the lot numbers on the wrappers. And at some point, I just look at the person and say, look, if I'm having to go to this length to determine if you're actually taking the medicine, there's something very wrong with what we're doing here. And that just means I just don't trust that you're taking the medicine. So I'm just going to put that on the table and let's talk about that issue instead of being a detective and seeing what's going on.
And that's the approach we use. If we're working harder at this than the recovery work, it's not connecting somehow or other.
Right.
We do routinely, yes, we do the Buprenorphin, but we also have, and Dr. Larson can speak to that. He can tell us if the dose is consistent with what they're getting. So are the levels consistent with whether or not they have Hep C, et cetera, that if they're on 6 milligrams, is it consistent with that? Or they're on 12 milligrams and they're only showing 6. So we can get to that level with particular testing we do. And so we do address that.